Good morning, everybody. Welcome to our LT Senior Services webinar for April. And we're just going to let everybody start coming in. We have a whole bunch of attendees, close to 100 will be here today to listen to our topic on strokes. And we're so happy to have you here. My name is Cindy Cummings, and I'm one of the founders of LT Senior Services. We are a nonprofit that helps serve the needs of seniors in the Lake Travis School District. And with our webinars, what's been really great is we've been able to reach people from all over the country. We have people who log in from all over to hear our webinars because you don't have to come into Lakeway. So we're so excited to have you all here today. I wanted to let you know about our upcoming webinar. So in April, let me go ahead and tell you what that's going to be. If I can find it here. So in May, on May 10th, we're going to be talking about aging in place and preparing for emergencies, which is a quite interesting topic right now because we had SNOVID, as we call it, and there were a lot of things that went wrong for seniors, particularly seniors who live in senior living kinds of communities. And so what people found is there needs to be some solutions for these emergencies in the future. So sad that emergency had to happen for us to think about this more, but it's been on our plate for about 6 months. We've talked about LT Senior Services preparing emergency kits for seniors when something like a SNOVID happens. And I was kind of wondering what I would put in our emergency preparedness kit, but having gone through it, I know much better what I would want in an emergency kit, but it's just something that's been on our mind and something that we've been wanting to work on. So that's going to be May 10th. June 14th, we're going to talk about current products and technologies for home safety and accessibility. We're really excited about that topic. We hope to bring to you items and products that will help you in your home so that you're able to stay in your home, living there longer. And as we know, most people do want to stay in their home and live. So excited about that topic too. So that's in June. We have a webinar each month, and we'll have one in July and so on and so forth. So welcome. We also wanted to talk about our expo. So we've had our expo in the past live, and it's a senior wellness expo. We're doing it live again this year. We're excited. It's going to be September 27th. And we're going to have speakers that will start at 9. We'll have exhibitors that will go from 9 to 12:30. And then from 1 to 2:30, we're going to do a job fair, which we did 2 years ago. And what we're finding is our unemployment rate is extremely low in the Austin area. And we have people who want to work. They might want to work part-time, they might want to work on commission, they might want to come into someplace to work. Some people need health insurance. So what we did last time was we had this job fair, and the job fair was for those who are over 55, and it was businesses who were wanting to hire people who are over 55. So we had a lot of success stories. It was a great event. I think we had about 12 I can't remember exactly, 12 exhibitors who were there. So we're excited to offer that again. That'll be from 1 to 2:30. We'll also be offering the flu shot. So you'll be able to get your flu shot. And if you have Medicare, you can just charge it through your insurance. Without further ado, I'd like to introduce some of our members of LT Senior Services. We have about 40 members, and the members are both nonprofits and for-profits. And one of our nonprofit members is the library. And so, Karen, are you here from the Lake Travis Library? And you're going to see our faithful assistant, Natalie. She's on, and she's working the controls in the background for me right now. Natalie, do you see Karen? We see Anita Rice. Is that somebody stepping in for Karen, maybe? Oh, here's Karen. Hey, Karen, we can't see you or hear you yet. There you are. Hey, welcome. Tell us what's going on at the library. I heard the Austin libraries were going to be opening soon. Is that a rumor or true?
No, I think it's public knowledge, and they've announced it. I think they said they're opening May 10th, although don't quote me on this. Definitely go to Austin Public. We are definitely working on opening. We're not allowed to announce a date, but we're definitely working on it. So I know that you're all wondering that. And when we do open, the doors will be open, but we'll be encouraging people to just sort of come in, get their items and leave, not hang around too much. The chairs are all being moved around, so you won't necessarily be able to sit or work or anything as you did before, unless you want to outside. Outside's been available the whole time. And in the meantime, we're still doing curbside, so you can reserve your items. You can contact us, we'll pull them, and then we'll put them outside. You can check them out. And we're still doing online programs, so Great Decisions is still happening on Zoom. We have like an African storyteller coming. There's a Learning with the Library series, Wednesdays at 2. So it's all on Zoom just like this, and that will continue.
Excellent. Well, thank you so much for being such a great partner. We really appreciate you getting the word out too via your marketing about these upcoming webinars. You are truly a great partner of ours. So thank you again, Karen, for coming and telling us about the Lake Travis Library.
Thank you, guys.
All right. Anita Rice, would you like to come in and say hey?
Good morning.
Good morning.
I've been enjoying the series for a couple of years now.
Oh, great. Are
Mhm.
you one of our members of LT Senior Services?
Well, I'd like to think I am.
Oh, awesome.
I
Okay.
don't know how official that is, but I was lucky enough to catch a couple of in-person classes here at the Twin Oaks Library here in South Austin. And so that was very nice. I really enjoyed those. Then we, of course, had to switch over to this virtual series, and I've been enjoying them ever since.
Well, excellent. Thank you for giving us that testimonial. We appreciate it. We do hear from a lot of people that it's been really helpful. I'm looking over in the chat right now, and somebody is saying, I'm attending from the United Kingdom. So that's really cool too, so that we can have people from all over. Well, without further ado then, I think what we'd like to do is go ahead and introduce our doctor. Natalie, if you'll help everybody else get off the screen so that we just have the doctor moving forward, that would be great. So Dr. Freeman, welcome, welcome. How are you today?
I'm doing well. Thanks for having me.
Absolutely. Well, I've got an intro. I'd like to go ahead and read it if I could. So Dr. Blake Freeman is a neurologist, and he treats a variety of adult neurological conditions and disorders with a special interest in epilepsy, cognitive disorders, movement disorders, and headaches. He performs EEG studies for evaluation of seizures and related disorders, as well as device programming. In his free time, he enjoys working out, mountain biking, and live music. Well, good thing, because you live in Austin. Those are all the reasons why people live in Austin, right? Medical school, he went to University of Texas Medical School, San Antonio. He had intern and residency of neurology at the University of Texas Southwestern Medical Center in Dallas, a fellowship in epilepsy in the University of Texas Southwestern Medical Center in Dallas. He's board certification in neurology and epilepsy, professional memberships in American Academy of Neurology, American Epilepsy Society, Texas Neurology Society, and Texas Medical Association. So that is what we have on a bio for you. You are at the Lakeway, Baylor, Scott and White, and you are here today to talk about strokes. And we're just so pleased to have you. Thank you for taking the time. So our format will be, you'll go ahead and present some information. We might have some questions in the chat that we'll ask you, and we'll go from there. So without further ado, the screen is yours, Doctor.
All right, sounds good. Let me see if I can get this to load. It'll take me just a second.
Looks beautiful, Doctor.
I'm just gonna change. Here we go. All right, can y'all see the presentation?
It looks gorgeous.
Awesome. Okay, so like she said, I'm Dr. Freeman. I'm a neurologist here at Baylor, Scott and White in Lakeway. I've been in Lakeway for about 2.5, approaching 3 years. So today I'm going to cover stroke. We're going to cover a variety of different topics. First of all, we're going to start with kind of an introduction into stroke, define a few terms. That should help provide a framework for the rest of the talk. Then we'll delve into identification of different signs and symptoms of stroke, how to know that someone may be experiencing a stroke. We'll talk about various risk factors for stroke, so kind of stratifying individuals' risk for stroke, things you need to be aware of both personally and for family members. We'll talk a little bit about the different causes for strokes or mechanisms of stroke, and how we determine that. Then we'll talk about some various treatment options. We'll talk about acute treatments, so what we do when someone's having in the midst of a stroke. And we'll also talk about some preventative treatments as well. And then we'll talk about what you can do to lower your risk, or what an individual can do to lower the risk for stroke. So let me just move this. Okay, so stroke, the definition of stroke is basically a neurological impairment that's caused by disruption of the blood supply to a region of the brain. What this amounts to is an area of the brain that's not getting enough oxygen or nutrients. The brain is exquisitely sensitive to being deprived of oxygen, being deprived of nutrients. Even a very short span can cause patients to have pronounced symptoms. It's important to know that if the blood flow to the brain is disrupted for a sufficient period of time, it can cause permanent damage. And the more time that goes by, the more tissue is at risk for not being able to have function restored. It's really imperative when someone's having a stroke to recognize the stroke signs and symptoms, and then to act quickly. And we'll talk about the different types of treatments. The graphic at the bottom just kind of illustrates why it's so important to identify and act quickly when someone's having a stroke. As you can see, initially, a stroke may affect this dark area, may affect only a small region. And then there's an area around the core, this kind of lighter purple area, where that tissue is at risk. So if we intervene, we might be able to prevent it from being damaged permanently. But if not, as you can see, that area, that core infarct, that dark area can expand with time. So, we refer to this as time as brain. So that just kind of emphasizes the importance of acting quickly to restore as much function as we can. There are basically two broad types of strokes. So there are ischemic strokes. This is what most people think of when they think of stroke. It's caused by a blood vessel supplying a region of the brain becoming compromised or occluded. It's usually due to a clot. And this represents the majority of strokes. Over 85% of strokes are ischemic strokes. Ischemia is when the blood supply is cut off. And then there are hemorrhagic strokes. These are not due to blood supply being cut off, but actually due to bleeding around the brain or into the brain tissue. And this can be due to multiple different factors. Cerebral aneurysms can cause bleeding, or it can be due to damage to small vessels that penetrate deep into the brain. And you can see examples of both on the graphics to the right. The first is an example of a blood clot that lodges in an artery, and then the region of the brain that's supplied by that artery can be damaged. You contrast that with the hemorrhagic stroke, which is, again, less common. And this can involve bleeding, or blood escapes that blood vessel and perturbs the brain tissue around the blood products. Both of these types of strokes can be life-threatening, and the treatment is very different for ischemic stroke versus hemorrhagic stroke. And so that's why it's critical very early to identify what type of stroke we may be dealing with. There's also a term that I'm sure a lot of y'all have or may be familiar with, or at least have heard, and that's TIA, or transient ischemic attack. Conceptually, this is very similar to an ischemic stroke. Other sort of terms that can be used are temporary stroke, or mini stroke, or aborted stroke. Basically, it's the same sort of concept. So you have a clot generally that may be lodged in a blood vessel, and then it may cause stroke symptoms. It looks just like a stroke, but your body has sort of its own way of dissolving clots. And in some cases, that may be sufficient. You can actually, your body may dissolve the clot and restore function. And patients with TIAs, by definition, don't have long-term symptoms from that. And it is very important to recognize, because an individual that has had a TIA recently or has had multiple TIAs, those patients are going to be very high risk for having a stroke over the short term. And that's why it's so important, even if patients have the stroke symptoms, but they go away in 30 minutes, an hour, or several hours, it's still important to have those patients evaluated, because it is a sign that there could be a looming stroke, and we need to assess what is the risk, and implement some sort of strategy for treating that or minimizing the risk. Some statistics, I don't want to get too bogged down in this, but I think it's also helpful to recognize some statistics related to stroke. Every year, there are about close to 800,000 Americans will have a stroke, either a new stroke or a recurrent second, third stroke. On average, a stroke occurs every 40 seconds in the US. It's one of the most common reasons for neurologists to be consulted in the hospital. This is a pre-COVID statistic, so this surely has changed, but historically, strokes are around the 5th, 6th leading cause of death in the US. It kills more than 140,000 people per year. And then there's a significant cost also, healthcare cost and burden related to stroke, both dealing with them acutely, and then things like lost productivity, disability, long-term rehab. So it actually costs the nation about $34 billion annually. So so that's one thing that we always have to be aware of as well. One thing that I think is very important, which I'll stress throughout the talk, is about 90% of stroke risk is attributed to modifiable risk factors. So these are things that individuals can control with the help of a physician. These are things that we can control to some extent and reduce one's risk for having a stroke. These will be things like high blood pressure, obesity, diabetes, elevated cholesterol, etc. And a significant portion is due to lifestyle choices too, things like smoking, not being physically active, not eating a healthy diet. And then other things globally, a significant contributor to stroke is actually air pollution, that especially in developing nations and surely in the US as well. So those are all things that we have to be mindful of. Stroke is not just due to one specific cause. Often there are multiple factors at play. It's important to recognize that there are acute treatments that are available for stroke. So there are things that we can do to intervene if caught early that can help reduce disability and potentially reverse the stroke symptoms. So I want to talk a little bit about how you might recognize someone's having a stroke. What are some of the more common signs or symptoms? A stroke in general is not something that comes on gradually, not something that comes on over a few days or a few weeks or months. This is usually, these sort of symptoms that I'm talking about are going to come on fairly quickly or fairly abruptly. These can be things like difficulty speaking, either difficulty getting words out or understanding what other people are saying to you. Patients can appear confused. Patients may have what we call lateralizing signs or symptoms. So these are signs that occur on one side of the body. And that's kind of a general rule for how stroke symptoms may present, is one side of the body affected more than the other. And there are exceptions, but that's, again, kind of a rule of thumb. So patients may have weakness or drooping of one side of their face, weakness on one of their arms or legs, numbness on one side of the body. Patients may have difficulty or vision changes, either loss of vision in an eye, or difficulty seeing out of one half of their visual field or their world. Difficulty with coordination, sudden gait changes, sudden onset headache can also be a sign of stroke, especially a hemorrhagic stroke. So these are all some of the more common signs of stroke. In general, some of the one sort of mnemonic that we use is this acronym FAST. And I think it's very good at recognizing the key features of stroke. It's not comprehensive, but it's easy to remember and helps patients. Obviously, if you're suspecting stroke, that's anxiety provoking. So if you can think of something that helps you recognize quickly signs of stroke, this is it. This is one of the better sort of mnemonics that we have. So again, it's FAST. The F stands for face drooping. So one side of the face appears weak. You can ask an individual to smile, and you may notice that one portion of their mouth is not elevating as the other is. That's a sign of stroke. Arm weakness. A is for arm weakness. So you may ask an individual to raise both of their arms just straight out ahead. And if they aren't able to lift one arm all the way up, or if they do lift their arms and then one kind of gradually drifts down, that's another sign of stroke. S is for speech difficulty. So again, difficulty getting words out, slurring of speech, or difficulty understanding speech. So often you can just give an individual a simple phrase, see if they can repeat it, see if it sounds different than it normally does. If you notice any of those symptoms, T, time to call 911. So you want to call 911. You don't want to wait. You don't want to see if it gets better. You want to seek medical attention right away. So this is a helpful acronym. I'll go over it again at the end of the talk because I think it's so important. So once we recognize or suspect that someone's having a stroke based on those signs or symptoms, they'll generally call 911, be taken to the hospital via EMS, and then the diagnosis of stroke is, well, it has a lot of elements, a lot of tests that we can potentially order to identify a stroke. We'll often start with head CT. That's kind of the initial imaging of choice. But it can also involve things like, so the top series is a CT. The second series is what's called a CT angiogram. So this is a test that looks at blood flow in vessels. And sometimes that can identify a stroke that may not be picked up on initial CT. We also have things like a little bit more advanced imaging, what's called perfusion studies, CT perfusion, where it gives us this kind of graphical representation of blood flow to different regions of the brain. And that can be very helpful in determining how we may or may not treat an individual. And then there's also imaging such as MRI, which we can't always get right away, but it's very helpful in determining what is the distribution of stroke, what sort of pattern are we seeing, and it can clue us into what might have caused it. We'll also, there are certain blood tests that can be helpful in stratifying an individual's risk for stroke. It's very important to also look at things like carotid imaging, looking at individuals' cervical arteries or arteries in the neck. And then looking at heart, structural heart imaging, usually an echocardiogram, and then monitoring an individual's heart rhythm. Those are kind of the core components of working someone up for stroke and determining what the cause may be. I'll give you just kind of an example of a patient that may present to the ER with stroke symptoms. This is an individual that, just based on this imaging, may present with left-sided weakness. They may have a facial droop or not be able to lift their left arm or left leg, may have some slurred speech. I'm just basing that on what we're seeing on the imaging. So we'll often start with initial imaging, see if we maybe see some signs or symptoms of stroke. How severe is it? We may get additional imaging like this perfusion scan on the right, which you can see. Blue is this normal blood flow. Red that's the area of stroke. That's the core infarct. And then this green area is tissue that's at risk. So this is area that if we don't intervene, all of this green area could be damaged, and patients could have a very devastating stroke syndrome and a lot of disability related to that. This again just illustrates the core infarct and then the areas circumferentially around it that are at risk but not yet permanently damaged. So how do we treat an individual that presents like that we identify a stroke, we identify that there's an area that's not getting good blood flow, and then there's more areas that are at risk? Well, we have a few different sort of strategies or treatment options available. One of the historically and still to this day, one of the most commonly used acute interventions for an ischemic stroke is going to be a medication called TPA, or tissue plasminogen activator. Sometimes this will be referred to as a clot busting medication, and that's basically how it acts. So you can see on the right, there's an illustration of a blood clot that becomes lodged in an artery. So it's obstructing blood flow beyond that blood clot. These patients, after they undergo the initial workup, identify that there's no contraindications for administering TPA. We'll give the medication, the clot busting medication, that travels, it's generally injected through a vein and then travels to the area of blood clot and helps to dissolve that blood clot, break it up, and restore blood flow. And that can restore function and minimize long-term disability. Not every patient is a candidate for this sort of intervention. Again, there's a lot of things we have to consider in terms of bleeding risk. How long have they, how long from the symptom onset did they present? Usually we try and administer this within 3 hours of symptom onset, but we can, in select patients, extend that up to 4.5 hours. So we don't have a lot of time to administer the medication. Again, that's why it's so critical to recognize the symptoms early and act quickly. We do have other interventions which can be used also within that time frame, but even a little bit longer, 6 hours, 12 hours, in some cases, even up to 24 hours. Those are not very common that we have patients that we can extend the treatment to, but there are select patients that may benefit from that. This basically is what's called endovascular reperfusion therapy. So these are catheter-based treatments. So a small wire that's inserted into one of the arteries, usually in the groin, and then it's guided up to the area of clot, and we can help to remove or dissolve the clot with that sort of intervention. These are, again, not every patient's going to qualify for this, but especially patients that are having a real devastating stroke, that we identify a clot on the imaging. Those are the patients that may significantly benefit from this sort of intervention. I'll actually kind of walk you through what that looks like, at least in a graphical representation. So this first image is, again, a clot that's sitting in a blood vessel, and it's obstructing blood flow to an area of the brain. Again, we can insert or this is done by a neurointerventional radiologist or a neurointerventional neurosurgeon, very specialized treatment where we insert a catheter, through the artery, travel up to that area of clot, which is up here, and we approach it with the catheter. They insert a guide wire through the clot, and then you can see there's a stent. It sits at the back of that guide wire. And again, this goes through the clot. We expand, or they expand the stent retriever, so it grabs onto that clot. And then the stent retriever is retracted. So they retract the guide wire just in reverse fashion and can remove the clot and restore blood flow. So that's kind of how the endovascular treatment option works. This is an example, again, of that same patient where we see this initial area of impending stroke. We see there's this core infarct, this area is at risk. This patient was able to get the clot resolved through intervention and through TPA. And then you can see that blood flow is restored, and this patient has really minimal, if any, deficits. Now it doesn't always work that smoothly, but that's kind of the principle that these therapies are based on. I included this slide not to overwhelm you. I don't want you to get too bogged down in the details, but it's really just to illustrate that when someone comes in with stroke signs or symptoms, we have to act very quickly. There's a lot of steps. This is a team approach. There are multiple specialists, multiple nurses, EMS technicians, radiology technicians that are working in concert to identify these patients, quickly take them to a CT scanner, get the needed labs, identify what sort of pattern we're dealing with. Do they need additional imaging? What is the time frame for that imaging? Does it look like this is a candidate for TPA, a candidate potentially for clot retrieval? And then calling the appropriate specialists, implementing that treatment, and trying to do it as quickly as possible. Again, concept of time is brain. So, it really is a team approach, and there are a lot of things that are going on when we evaluate patients for strokes. So that's kind of the acute treatment. Now I wanted to take a couple steps back and talk about risk factors, because this is actually very important in preventing or lowering one's risk for stroke. I talked about 80% of strokes are due to these risk factors. So we want to try and control them as best we can. There are some risk factors that are not modifiable. Age, for instance. Stroke risk does increase with age. There are other sort of genetic components that really aren't within our control that can contribute to one's stroke risk, but I really want to focus on some of the more modifiable risk factors. So these are things like high blood pressure. That's one of the most common risk factors for stroke. So identifying and addressing blood pressure, identifying different types of heart disease, abnormal heart rhythms, individuals that have diabetes or elevated blood glucose, trying to get that under control. If someone smokes, stopping smoking, or coming up with a strategy to stop smoking, identifying what is a healthy diet? What sort of things may an individual be eating that can increase their stroke risk, and addressing that appropriately? Identifying, are there any medications that could potentially increase one's risk for stroke? And then things like alcohol use. Alcohol in excess can certainly increase one's risk for stroke. And then physical activity. So trying to maintain, regular physical activity is critical. This is a study, again, don't expect you to analyze this in too much detail, but I will show you, this is kind of a landmark study for us. I'll give you just an example of one extreme versus the other. So in column F, these are individuals that are at high risk for stroke. So if you follow this down, this is column F. These are patients with elevated blood pressure, diabetes, history of cigarette smoking, atrial fibrillation, cardiovascular disease. And as you can see, their risk for having a stroke, 10-year estimated risk, is about 22 to 27%. So high. You contrast that with an individual at category A, which is low risk individuals. This is someone that has controlled blood pressure, doesn't have diabetes, doesn't smoke cigarettes, doesn't have atrial fibrillation, doesn't have cardiovascular disease. And these patients, 10-year, 2.6%. So that just kind of illustrates there's objective data to support all of these risk factors contributing. Let's see. So this is put out by the American Heart Association, American Stroke Association. It really tries to kind of simplify and identify what are the most common modifiable risk factors and how do you address that. So again, we talked about this a little bit, but stroke, blood pressure is going to be, the elevated blood pressure is going to be one of the most common risk factors for stroke. So identifying that, trying to work with your doctor or your cardiologist to make sure you're on appropriate medications, lose weight if that's contributing, to help keep your blood pressure in a normal range. Reducing blood sugar, especially if you have a history of diabetes or pre-diabetes. Coming up with strategies, talking to your physician, potentially medications that can help lower blood sugar. Controlling blood cholesterol. Again, this can sometimes be treated with diet alone, but not uncommon. We have to give medications like statin medications to help lower cholesterol. This depends on the individual, and again, working with your primary care physician can be very helpful in addressing that. Eating better, decreasing sodium intake, trying to emphasize green leafy vegetables, fresh fruit, trying to minimize heavily processed foods. Physical activity, recommend 30 minutes, 5 times a week of regular physical exercise. This is needs to be something you enjoy and something you tolerate. Avoiding smoking, and then trying, if an individual has obesity, trying to lower their weight. These are all kind of the main tenets of the reversible or modifiable risk factors. Again, 80% of stroke and heart disease may be preventable by addressing these risk factors and others. There's, I talked about the sort of acute treatment or medications that we can use for individuals that are having a stroke, but it's very important to also recognize there are preventative medications, which in someone that may have a lot of risk factors or may have a history of stroke, there are medications which can be used to minimize the risk for stroke moving forward. And, again, these are things like blood pressure medications, cholesterol lowering medications or statins, blood sugar lowering medications. And then very importantly, anti-platelet medications or anticoagulant medications. Examples of antiplatelet medications are going to be things like aspirin, Plavix, sometimes even in combination. Anticoagulants will be things like warfarin or some of the newer medications like Eliquis, Xarelto, that are used in specific circumstances. Not everyone qualifies for those sort of treatments. So it really depends on the individual and what sort of medical conditions they have. I'll give you some additional stroke resources. These are very helpful. One is stroke.org. They have a treasure trove of different resources that you can look through. Stroke Association is very helpful, strokecenter.org. These are kind of the three main resources that I go to when I'm counseling patients or want to give them some additional information to read. And then there is also a stroke support group at the Baylor Scott & White Institute of Rehab. And there's some information on that as well. Again, because I think this is so important, I just wanted to go over that acronym again, FAST. These are identification of stroke signs or symptoms. So F for facial drooping or asymmetry, A is for arm weakness, S is for speech difficulty, T is for time to call 911. If you identify these strokes, you want to get that patient into the hospital as soon as possible so we can treat them appropriately. All right. Okay, well, I'll open it up for questioning. If y'all have any questions?
We've got some questions. I'll read them to you, Doctor. The first one is, what causes a clot in the brain?
Well, yeah, that's kind of a complicated answer because there are multiple different potential sources or nidus for stroke. There's what we call small vessel disease. This is deep penetrating arteries that are very small caliber, which over time can develop, can become restricted, or what's called lipohyalinosis. And over time, they can reach a threshold and they may become occluded. And that's one cause of stroke, one of the more common causes. Also, strokes can come from larger arteries, so bigger caliber arteries, or potentially the carotid artery in the neck, where they form atherosclerosis. It's a little bit different process. It's basically a plaque that can break off and travel to some of these more distal vessels. That's a potential source. And then another source we're always on the lookout for is strokes that come from the heart. These would be things like atrial fibrillation or abnormal heart rhythms, which can form clots, or valve or vessel valve disease, which can also form clots. So those are kind of the main causes of stroke. There's some less common causes as well, but those are common sources of clot.
Tell us a little bit about the difference of men and women with strokes. Do you see a difference?
Yeah, there's, there are different risk factors based on sex, and there can be a little bit different presentation depending on male versus female. This is, what I'll say just in general is they present very similarly. But in terms of the sort of real objective signs, there's some literature on, female patients maybe having some other symptoms that may be a little bit more prominent, like nausea, confusion, but in general, they present very similarly, male versus female. In terms of risk factors, the main difference may be hormonally based. So in particular, individuals that may be on certain hormonal replacement therapies, for instance, that could be females that are on hormonal replacement therapy might be at increased risk for stroke. There's, in general, the same sort of risk factors are applicable male to female, but there are some subtle things to kind of keep in mind.
Tell us a little bit about the staffing at Baylor Scott and White in Lakeway. Do you have people on call? How does that work now? And actually, I've had the opportunity to visit with several of you, with both me and for my mother. I think you guys are there all the time, or somebody's there, right?
Yeah, well, we do have a system in place that there are stroke neurologists available around the clock. Not necessarily in person. We, as with most major hospital systems, we have a telestroke service. So we, of course, have emergency physicians that are in the ER around the clock, no matter the time of the day, that are there. Those are the boots on the ground, first patient or first set of eyes that are going to identify stroke signs or symptoms, determine, is this a stroke or could this be some other sort of process? If it's determined this is an acute stroke, the telestroke neurologist is immediately notified and responds within a matter of a few minutes. Usually we'll use some sort of video interface. Sometimes it may just be over the phone if there's some sort of connection issue, but they're communicating with that ER doctor and helping to determine, is this a patient that looks like they're having a stroke? Determine the type of stroke this may be, determine what sort of imaging, and also very importantly, determine what sort of treatments do they qualify for, and then acting very quickly. Again, it's all based on time. So we have these sort of systems in place that we can act quickly, and we have stroke neurologists that can evaluate these patients no matter when they present.
I think what we've heard is one of the best things that happened with COVID was the ability to operate this way, because it wasn't always so easy and there were so many restrictions in place, I think, for hospitals to get payment and things like that. So being able to have the doctors on video call is amazing. And I know I've done a ton of video calls during the COVID, and it's super convenient.
Yeah, it's it has definitely opened that up for a lot of patients, a lot of physicians. I will say the telestroke neurology is not a new concept, though. We were using this, one of the specialties kind of pioneer the telemedicine. And so this has actually been used for, a number of years, actually better part of a decade. This isn't kind of a new concept necessarily for us, at least with regards to stroke. But yeah, you're absolutely right. In terms of a lot of the other sort of evaluations, that's COVID has really changed the landscape and made
It really has.
I think in a lot of ways it's been good. Yeah.
Yeah. So tell us about the difference between a stent and a balloon, and are balloons still used?
So it's, again, this kind of depends on the interventionalist, what their approach is, what they have available. In general, the stent retrievers have kind of supplanted, a lot of the previously used devices. Some of the stent retrievers do have sort of a balloon mechanism to expand the retriever. I'm not a neurointerventionalist, so I'm not in the IR suite doing these sort of interventions. I may not know that technical, when one might be used versus another, but in general, most of the mainstay of these sort of endovascular reperfusion are using these stent retrievers, like I showed you on the graphic, where they're expanded based on a coiling, and then they can be retracted and remove the clot.
Excellent. This is a great question. Somebody is saying, my mother had a significant stroke, and with it, she got really angry and snatched something away from a caregiver's hand. Can strong emotions be a symptom of a stroke?
Yeah, it's a good question. It's, yes. The short answer is yes. There's, strokes can certainly cause behavioral changes. It really depends what region of the brain may be affected. There's certain sort of brainstem syndromes, for instance, which can cause sudden mood changes. It depends on the territory, the extent of the stroke. Strokes can affect cognition, depending on the location, and that can also affect mood. So yeah, stroke can unfortunately affect mood. It can make patients more irritable, but it's really, it becomes kind of a more complicated or nuanced answer because it really depends on what is the territory that's involved, you know, to predict that. And sometimes we can't predict it. You know, someone may have a stroke symptom and we see where the stroke is on MRI, and they may have some unexpected symptoms as a result too.
So I guess we need to be patient with our loved ones if they've had a stroke and they might have some of these issues. Hey guys, if you would put your questions in the chat or the question and answer, we won't be able to do a raised hand and have you come in and ask the question. Are the BWS stroke groups also for people with TIAs? I had a TIA for the first time last month. I couldn't get words out for 15 minutes and no other symptoms. So do you know, can those people participate?
Yeah, so we, you know, it's not uncommon to have patients present with TIA symptoms to the ER, and they're basically triaged or handled just like we would a stroke patient. Oftentimes, you know, even if the patient's symptoms resolve spontaneously, we'll, unless those individuals are very low risk, we'll typically admit them overnight to the hospital so we can get some of that diagnostic workup that I talked about, imaging, looking at the heart rhythm, and stratifying what is the risk for stroke moving forward. So
great. Should a person take aspirin after calling 911 if experiencing stroke symptoms?
In general, yes. There's, as I indicated, most strokes are going to be ischemic. So when blood supply is cut off, and those are the type of patients that may benefit from antiplatelet agents or aspirin. There are, again, about 15% of strokes may be due to hemorrhage or bleeding, and those are patients you wouldn't want to give an antiplatelet agent to, so, or, you know, blood thinning medication. It is kind of a, again, kind of a nuanced answer, but one of the more common sort of distinguishing features of a hemorrhagic stroke versus an ischemic stroke is if someone has a very severe headache at the onset, that's usually going to point you more towards a bleed than someone that, you know, has stroke signs but doesn't have the severe headache. Bleeds tend to have more kind of depressed level of awareness or, you know, unresponsiveness versus ischemic strokes. So in general, if someone has stroke symptoms, but they're not having a severe headache, they're not, you know, unresponsive, then those are the patients that you'd want to give an aspirin to.
Okay. Why do you say you can't always get an MRA right away?
Oh, yeah. So part of the reason we use CT initially is because, well, it's really good at ruling out bleeds or brain bleeds, which guides treatment. It's not as sensitive as an MRI for detecting early stroke. Again, our diagnosis is based on clinical signs, not necessarily based on the CT. It can pick up signs of stroke, certainly, or give us some clues that a stroke may be dealing with an early stroke, ischemic stroke, but it's really to rule out that bleed or some other sort of process that could be contributing. MRI takes longer. You know, patients are in the scanner for 30 minutes and we don't have, you know, 30 minutes to waste. CT we can get done within a matter of a few minutes. So CT is much quicker. It's all about time, so we generally don't have time to wait for an MRI. And then also, you know, CTs are more accessible. So, you know, we can generally get patients in, get the CT done, contrast that with the MRI where, you know, someone may be in the scanner already getting a scan. And so we have to wait for that. So that's why we generally get the MRI a little bit later.
Okay. This is kind of along those lines. What kind of imaging was showing you the images with blue, green, and red?
Oh, so that's a CT perfusion study. So it's
I think he might be frozen. We'll wait for a minute and see if he comes back, or maybe I'm frozen. Natalie, are you there?
Yes, I think it's Dr. Freeman that's
I think
frozen.
it's Dr. Freeman.
Okay. Hey, Jennifer, while he's maybe coming back up, I was going to ask you, did you want to say something about Baylor Scott and White?
I just want to thank everyone for joining today. Dr. Freeman is one of our specialists at the Lakeway Specialty Clinic here. And we also have Dr. Rivas Rodriguez. Dr. Freeman specializes in epilepsy and dementia, and Dr. Rivas specializes in MS. So we are also getting ready to launch a neurohealth institute that will be all encompassing. So you can do basically an umbrella of any neurohealth issues. And we'll have more details on that we'll be sharing with you in the next couple of weeks.
Excellent. We'll help you
looks
get
like
that
Doctor
word
is-
out.
Thank you very
Yes.
much. It looks like Doctor is back.
All right, Doctor, we're going to just keep on going through our questions. We've got quite a few. Do you have a little bit more time to spend with us?
Yeah, I do.
Great. So one of them is, are symptoms for mini strokes the same as a stroke?
In general, yes. Yeah, the TIA or mini stroke. I don't really like the term mini stroke, but I think it's okay to use. But that's generally referring to TIA, and the symptoms can be identical. They may not be as severe in general, but they can be virtually identical to stroke symptoms.
Here's an interesting question. What is going on when an older person is in the hospital and the doctors say they have had a number of strokes in the past? How do you know that they've had strokes in the past?
Yeah, so that's actually not all that uncommon to see in patients that come into the hospital, whether it's for stroke or maybe some other neurological condition, headache, dizziness, etc., to see evidence of old small strokes. And these may just be areas that an individual has a stroke to, but they're not in what we call eloquent areas of the brain. So they don't have real obvious clinical features. And so those patients may have had a stroke, but they're very small and they're not to an area that would really cause any sort of obvious signs. And so we do see that. So that's generally what we're referring to, and it's based on imaging, usually MRI. And so it's not uncommon to see that.
Mm-hmm. Is the Lakeway Hospital staff 24 hours a day with doctors, x-rays, technologists, et cetera, to treat patients that arrive with a stroke symptom?
Yes, we do. We're designed, as a primary stroke center to have around the clock, have availability of ER physicians, radiology technicians, and then again, that stroke neurologist available via telemedicine.
Excellent. If you have an MRI scan a month after a small hemorrhagic stroke, would it always still show up?
It depends. It depends on the extent. In general, you start to see resolution of those blood products. So you'll often still see some signs of a bleeding stroke, but at 1 month, but they change. It looks very different from if you have a bleed that occurred a few hours ago or 12 hours ago. Is going to look very different in a month, but you can still often see some changes.
Okay. I'm going to probably pronounce this wrong. Can a pericardial cyst cause a stroke? I think it's maybe the question.
Pericardial
cyst.
I'm not sure exactly what that's referring to, but there's a lot of different types of heart disease that can raise one's risk for stroke. So I'm not sure. Again, I have to maybe get a little bit more information on what exactly they're referring to answer that question.
I think we'll ask him to restate it maybe in a different way.
Okay.
Can epilepsy cause strokes?
Epilepsy doesn't cause strokes. If you have prolonged seizures, it can make you more at risk for having some brain tissue damage. If they go on for 12, 24 hours, 2 days, then that can cause brain tissue damage, but it's different from a stroke. But, actually what we see more commonly is the other way around, where patients may have a stroke and then that causes them to have seizures or epileptic seizures later on. And so it's more common to see it the other way, where you see someone that's had a stroke and then later on they may develop seizures as a result.
Interesting. Do you think the use of the term stroke should be changed to something like brain attack, as a lot of people do not know what a stroke is?
Yeah, it's a good question. Actually, at some centers like the Mayo Clinic, for instance, they use that term brain attack. And, it's basically kind of the same concept as a heart attack. And so, it's a matter of terminology. So, I can't say one's necessarily better than the other. I think stroke is a good term in terms of it implies that it's very sudden onset, quick, abrupt. But yeah, there certainly could be refined. And, there's sometimes you go to these conferences and they may be debating semantics or terminology. So yeah, that term is used elsewhere, different hospital systems. Stroke is certainly more commonly used most centers.
Makes sense. My question is, if the stroke support groups are open to people who've had TIAs. So if you know that, yeah, okay, they are. Okay, cool. Thank you. For hemorrhagic stroke, could you go over once more the therapies and meds involved in treatment?
Okay, yeah. So, the treatments, the acute treatments I talked about where we give TPA or go in and remove the clot, those are only for ischemic stroke. So hemorrhagic stroke, you don't want to give TPA because that will make things worse. And, there's not really a clot to target per se generally. So the treatment for a hemorrhagic stroke is really going to be very close monitoring of the individual. In most cases, we have to lower blood pressure. That's one of the big drivers for hemorrhagic stroke. And if it's not controlled, that can actually cause more bleeding. So that's kind of the main treatment is acutely or trying to lower one's blood pressure, keep it in a desired range. A lot of times that requires continuous IV medications, have to be monitored in the ICU. We have to keep a very close eye on patients that are having or have had a hemorrhagic stroke acutely, because we're always worrying about expansion, more bleeding. And so we'll often get, a series of images, when they come in, 6 hours later, 12, 24 hours later, to continually monitor, make sure it's not expanding. We'll often look at the blood vessel, see is there, a specific site of leak that may be at play. And then, it's also a lot of trying to avoid certain medications, which can thin the blood too. So in some cases, we'll even use reversal agents. If someone, was on an anticoagulant, had just taken it before they had the bleed, it's not uncommon to give them, a medication which can reverse that, or platelets, especially if someone's platelets are low.
Mm-hmm. Great, thank you. How to assess a small TIA later and how long after?
Yeah, I'm not really sure. It's the duration of the symptoms is really important. Make sure it's a TIA. TIA by definition needs to last less than 24 hours. The majority are going to be actually on the order of 30 minutes or a few hours. And then, making sure those symptoms were actually compatible with the TIA. There are other things that can mimic a TIA, for instance, seizure or, electrolyte abnormalities, infection. Those can sometimes mimic what might otherwise be a suspected TIA. So, trying to really drill down on what sort of symptoms the patient had and what was the duration.
Great. Is hereditary a risk factor?
Well, it can be. We certainly know that if patients have a real strong family history of stroke, they're going to be at higher risk for stroke. And that, again, is complicated by, did both their parents have stroke, but at the same time they smoked for 40 years, cigarettes for 40 years. And so that may not be due to genetics, but, tobacco use. So you always have to consider lifestyle when assessing an individual with a family history of stroke. But there are certain genes or certain other medical conditions which may be hereditary, which can also raise one's risk for stroke. For instance, some families may have high cholesterol levels. So it's important to monitor that, be aware of that, treat it aggressively. Other patients, you can have specific genes. It's pretty rare, but you can have specific genes that are associated with syndromes that can cause strokes too. But those are kind of the exception.
Excellent. So here's a long one. Let me try. I don't see anything about stress as a risk factor for stroke. How much would you say stress contributes as a risk factor? In other words, if you had otherwise healthy person, but they had high BP and an unusual high amount of stress in their life, would you consider them at risk for stroke?
Yeah, it is a risk factor. It's difficult to quantify. For instance, blood pressure, you have an objective measure and you can sort of correlate that with one's stroke risk. Same with cholesterol or diabetes. We have different biomarkers that can assess that. Stress is a little bit more nebulous, kind of hard to pin down. But certainly, if you're under stress, especially chronic levels of stress, that can reduce or that can increase inflammation. That can over time, cause the sort of atherosclerosis or small vessel disease to progress a little bit more rapidly than it might otherwise. And then blood pressure or stress can, elevated cortisol levels can cause weight gain, can cause blood pressure to go up. So it kind of has this indirect effect, and it's a little bit difficult to quantify, but it is certainly a risk factor.
Okay. I'm probably going to say this wrong. Would ascending aorta aneurysm increase chances of a stroke?
Yeah, it can. That's not a common cause of stroke. That's pretty uncommon to lead to a stroke, but it can theoretically, especially the ascending aorta, that could serve as a nidus for stroke potentially, but it's not a very common cause.
Okay. Well, we have one last question. I think it's just a great review. You've already told us this, but how do you know yourself if you're having a stroke?
Well, a lot of those signs that I talked about, facial weakness, weakness of your arms, numbness on one side of your body, those are subjective things that you're going to be aware of. There are, to kind of complicate matters, some of the, speech changes, for instance, you might not even be aware of just due to the kind of the wiring of your brain. You might not have awareness that you're talking funny, or there's certain what we call neglect syndromes where, by their very nature, you don't realize you're having a deficit. And, we do see those certainly, but most stroke symptoms you're going to have some awareness of, but there are exceptions. We do have patients that have pretty severe stroke and they're not even aware of it personally. It's someone else that recognized it.
Well, doctor, that is all the questions that we have. Is there anything else you'd like to share with us today before we sign off?
No, I think that's it. Like I said, I'm here in Lakeway. I do see patients in clinic. So, if any of y'all have any additional questions, I'd be happy to see you in clinic. I also work in the hospital. Very important to remember the FAST acronym. That's one thing I want you to really get out of the talk and have in your mind moving forward, know that you have to act quickly if someone's having signs or symptoms of a stroke. A lot of our acute therapies are time-based. So if you wait too long, we may not be able to treat you or maximize the benefit of treatment.
Excellent. Thank you so much, Dr. Freeman. Thank you, everybody, for attending. You'll be getting a follow-up email. It will have a link to our YouTube video channel where you'll be able to watch this video later if you want to share it with your friends and loved ones. Thank you again. We'll see you in May, everyone. Bye.
Thanks for having me. Bye.